Hello everyone, it's another Tuesday and you are welcome to Talking Health with Dr. Lars, your favorite health program on television. As usual, we are reaching you from Nigeria's capital, Abuja, and on Africa Independent Television, AIT. My name is Dr. Lars Eze. Yes, health workers are considered as heroes, especially since 2020 when COVID-19 has been causing a lot of challenges in the sector and overstretching them, even taking the lives of a number of health workers. They are considered as such because of the risk they take and, of course, the risks that they are opposed to, the efforts they make at saving lives. But health workers are humans too. They fell sick, they die, they have blood flowing in them. And something that's been happening in the Nigerian space over the past couple of weeks, where a number of health workers, specifically two medical doctors, have been trending on social media because they are asking for the public to help them to live again. Dr. Clement Ifen Koronye and Dr. Ann Okoma have end-stage renal failure or end-stage kidney failure, if you like, and they resorted to crowdfunding and raising money from the public, to be able to get themselves treated. And this happening have been causing a lot of questions. Of course, this is not the first time such is happening, many might say, but perhaps based on the debate around hazard allowance, debate around welfare for healthcare workers, and of course, many other persons working in the country, many are asking, should it get that bad where a doctor have to rely on public donations to be treated for a disease that have cure and a disease that's treatable? And since COVID-19, the issue of hazard allowance has become more topical. Recall that last year when the Association of Resident Doctors and of course the Joint Health Sector Union had to complain seriously, and the Presidential Task Force made a recommendation for 3 months for a major increase in hazard allowance because of COVID-19. But of course, there's been complaints that this hazard allowance, the increase was not sustained beyond the initial period, and health workers have been agitating based on the history of many losing their lives to Lassa fever, to other health conditions, and even those who don't lose their lives having to spend a lot of money out of pocket to get themselves treated. So this is the matter we'll be focusing today on the program. And I'll have two medical doctors and a medical laboratory scientist joining me on the program. Of course, one is in the studio and two will be joining us via Zoom. I'm going to be introducing them further after the break, but do not forget to follow us on our social media handles displayed on your screen, and feel free to make your comment, ask questions, and also get to watch the program, both the current, the previous ones, as well as future ones, as many times as possible when you subscribe to Talk Health Nigeria TV on YouTube. Do stay with us, we'll be right back shortly. Welcome back to Talk Health with Dr. Lars, your favorite health program on television. So let me quickly introduce my guests. Let me start with those joining via Zoom. Dr. Kenneth Okoro is the past National Secretary of Nigerian Medical Association. He's joining us via Zoom from Abakaliki in Ebonyi State. You're welcome to the program, Dr. Kenneth Okoro.
Good evening, viewers, and thank you, AIT, for having me.
You're welcome. Thanks for being with us. We also have...
It's my pleasure.
Yes, we also have Dr. Chimezie Kwano. He's a consultant nephrologist. A nephrologist is a specialist in kidney matters. He's a kidney care and kidney transplant specialist, and also the chairman of Nigerian Medical Association in Abia State. Joining us via Zoom from Umuahia. You're welcome, Dr. Kwano.
Yeah, thank you for having me. Good evening, my viewers.
It's a pleasure to have you, sir. And right here with me in the studio is a medical laboratory scientist and a member of the Make Our Hospital Work campaign, Mr. Favor Nnadi. You're welcome to the program.
Thank you very much, Dr. Lars, for having me on the studio today.
Great. Thanks, all of you. The matter today is talking about healthcare workers, and I think it's something that is of interest for all of us as health workers. But I will start with Dr. Chimezie Kwano because of the cases I cited And one of the medical doctors who needs help, especially Dr. Clement Ifen-Koronye, works in your hospital. But before we discuss specifically about his case, perhaps you kindly explain what end-stage kidney failure or end-stage renal failure means to the benefit of our viewers. What do we mean when we say that there is an end-stage kidney failure?
Okay. End-stage kidney failure means that the kidney have undergone some irreversible changes in the function and in the its structure, and this has gone on for at least more than 3 months. It is
Okay, sorry that we have technical challenges. I'll get back to Dr. Kwano as soon as we're able to connect back on Zoom. Let me come to you, Favor. There's been this conversation about the healthcare workers. As a medical laboratory scientist, what are the hazards that you potentially face when you are working in the lab?
Okay, thank you, Dr. Lars, for that question. We can group it into three. We have biological, we have the physical, and we have the chemical hazards. And this every day poses a risk to a scientist that is doing his or her job to produce results. And every day we see it mostly, and these three I've mentioned, the biological hazard has the highest ranking. Like almost 70% of the hazard faced by a scientist in the lab is coming from the biological aspect.
So what are examples of those biological hazards?
Infectious diseases, the virus, the bacteria handling, and everything that has to do with microorganisms. That's the biological side. The chemical side talks about the reagents you're using in the lab. Some of them are toxic. Some of them, when you inhale them, they are very, very toxic to the system. So that is a side for the chemical. Then physical, the slippery floor. And sometimes you see that in the lab, when they build some lab, they don't build it with the concept of those who are going to make use of the lab. Sometimes they build a lab without a safety area, without some maybe workshop, without some areas that has to make the work of a scientist more better to avoid such physical hazards.
Okay. So I want to think that biological hazards might include Lassa fever, which many health workers have actually died from
it
when they get it. It might also include perhaps chicken pox, from the patient to the, there are so many of them. Do we have Dr. Kwano back on Zoom? Okay. So while we wait for them, what's there is being complained by a number of health organizations, including the Association of Medical Laboratory Scientists of Nigeria, about the low hazard allowance. So how does that make you feel, knowing that I think 5,000 is the current hazard allowance?
Yeah.
So what's the implication of that on service delivery?
Number one implication is that it demoralizes lab scientists to function optimally. Let me give an instance. Last year, when I was doing my NYC, they were called for volunteers when this COVID issue came into Nigeria. So when we went for the meeting and after the training and all the instructions, and I asked the question, if for any reason a lab scientist at the cost of doing his or her duty gets infected, what happens? Is there any insurance like for the family maybe at the worst case of death? So nobody was able to answer that question. You see, it's more demoralizing for a scientist or a healthcare worker, in as much as the pay is very poor, but sometimes insurance doesn't cover you at some stage of your practice. So it demoralizes the person who is doing the function.
So how will it affect the quality of service the patient is receiving?
One, because if there are lesser people to do the job, the work pressure is going to be high. Now, if the lesser people do the job, the turnaround time will be delayed. If, for instance, a result that should have come out in 1 hour or 2 hours time, because lesser people are agreed to take the risk do the job, you see that it may take 4 or 5 hours to come out. And the long run, the patient will be the one to suffer the delay in time.
Okay. So in this situation, what would you want the hospital management or the government at the state or federal level, whoever owns the hospital, what would you want them to do?
Okay. One is to help build confidence in the, let me just say generally, in the healthcare system. Because 5,000 naira is, even if you pay 1 million naira, it doesn't worth anybody's life. What I'm suggesting is that the government should build a system, or like a kind of a life insurance, that even if anything happens to you, we don't need to start, maybe we don't need to sell property to take care of you, because you got that stuff at the cost of doing your job.
Okay.
You understand? So the government should take full responsibility of the healthcare worker, increasing the hazard allowance from what you have to a better amount.
So now, hazard allowance and insurance, you can't have both at the same time.
Yeah.
So if you had to choose one, which one will you choose?
I would choose insurance. When insurance covers all.
Okay.
Yeah.
So some have also argued that there should be some package for the family should there be loss of lives.
Of course, because that person is a breadwinner in a family. He or she is a breadwinner in a family. Somebody trained that person. So if, for instance, somebody gets maybe infected at the cost of doing his or her job, and that thing takes her life or his life, then the family should be compensated duly.
Okay. The various professional groups in the health sector are used to fighting, especially at the teaching hospital level or the tertiary level. So do you see this thing as something that can bring them together to push?
Yeah, I think it's one thing that affects everybody. Whoever, be it Mr. A, be it Mr. B, be it Mr. C. And we must come together to find a lasting solution to it.
Okay.
Because it's a teamwork. And once one team is affected, if you're playing the football match and your keeper or anybody is affected, entirely the whole team is affected. So we need to carry it as a thing, as together.
One people. Okay.
Yeah, one
So
people, yeah.
thank you, Mr. Favor Nadi. I think I will have to go back to those, we get the system fixed, and let's have those couple of doctors joining us on the program. But we'll be right back after this break, and I look forward to continue this conversation. But thank you, Mr. Favor Nadi, for being on the program. I look forward to seeing Johesu, NMA, everybody uniting to push strongly for, enhancing the health workers' access to healthcare without having to sell their properties or beg in public. Do stay with us. We'll be right back after this break. Welcome back to Talk Here with Dr. Lars, your favorite health program on television. Yes, record at the beginning we had some technical hitches, but we've been able to reconnect with one of our guests who was on Zoom. Dr. Kenneth Okoro, welcome back to the program.
Thank you for having me.
Thank you, sir. So we have barely 10 minutes. Sorry about the technical issues we encountered. Essentially what we're talking about is the hazard faced by healthcare workers, their access to healthcare, especially those who require so much money for treatment, and how the system is failing them. How many of them will have to go in public to beg for money? I was asking Dr. Kwano to explain what end-stage renal failure means, and he had already said that, yes, it's when the kidney in its functions and structure is unable to perform. So, what I want to ask you, there's been a lot of complaints around the hazard allowance. You were the National Secretary of Nigerian Medical Association when the COMMES, the Consolidated Medical Salary Scale, and CONHES salary structure was approved. And I assume you were part of the negotiation that saw to the 5,000 naira hazard allowance. That's about over 10 years ago. So what was it like? How did you come about the 5,000 naira as hazard allowance for medical workers, as at when this was negotiated with the government?
Thank you, Dr. Lars. Actually, the hazard allowance of 5,000 naira was more or less on the insistence of the government team. We knew ab initio that 5,000 naira hazard allowance for all the health workers was certainly nothing to cheer about. The NMA team then, that was in 2009, tried everything to see if it can be more realistic, but the government team insisted, and incidentally, we were working very hard to at least reintroduce the medical salary structure, which was suspended by the previous military regime. So we more like said, okay, what is offered, maybe we take it for now with the hope that in the not too distant future, it will rise upwards and be more realistic and more reflective of the hazards that health workers go through. And it's instructive that this salary structure was effected in 2009. And between then and now, the value of the naira has been devalued by over 300%. And we are being faced with increasing hazards, new emergent diseases coming up. Like currently we have COVID, and more health workers are getting infected in the course of performing their duties. And unfortunately, the hazard allowance is so low, and even the salary is such that, like I said, it's been devalued by over 300%, that it's no longer able to even assist the health worker take care of himself. And the result is that a whole lot of our colleagues are emigrating to other parts of the world, and the brain drain is real. So
yes,
it is really time that the hazard allowance be revised to be more reflective of the hazards that health workers go through, and be able to be reflective of what can make a health worker be even able to take care of himself.
Okay, if you are to recommend, like, how much would you want it to be increased to? Last year, the PTF made some increases depending on the cadre of the healthcare worker. Would you want that sustained over time, or would you want to make a fresh recommendation?
Indeed, the recommendations of the team then is even no longer realistic. On daily basis, the naira is being devalued. So if I'm to make a recommendation, I recommend something more like a 500% increase on what was recommended.
Okay, some have argued that hazard allowance may not be ideal because, for instance, one of the two medical doctors I talked about at the beginning who are looking for money for kidney transplant, one is looking for 10 million naira. The other one is looking for something above 20 million, around 25 million. So even if you increase the hazard allowance to, say, 1 million naira per month, it may still not be able to help in the event of catastrophic health expenditure, like kidney transplant. So some have suggested, what about a health insurance for all healthcare workers? You know, to be able to cater for whether it's kidney transplant, cancer care, heart disease treatment, and any kind of health condition whatsoever that a healthcare worker may face. So what's your opinion on that? Replacing the hazard allowance with health insurance?
That out-of-pocket expenditure for healthcare has failed and failed woefully. Indeed, health insurance is the way to go, and that is what is happening in places where the government, where the nation takes the healthcare of our citizens very seriously. Indeed, for quite some time now, the Nigerian Medical Association have been advocating for universal health coverage for all citizens, but taking it down to health workers who are more endangered because in the course of their duties, they are exposed to enormous risks, health risks. So it is necessary that even if universal health coverage is not possible in Nigeria at the moment, that health workers be targeted for a comprehensive health insurance package. For quite some years now, for us even in the Ebonyi State, as far back as the year 2000, 2001, doctors had to make contributions on the auspices of the NMA to assist colleagues who had critical illness, such as some of our colleagues currently in Abia State.
Yes, sir. So, sorry, I have to cut you. We are really short of time. So, if you have to choose between hazard allowance and comprehensive health insurance, would you want to make a choice of one, or would you want both of them retained?
Both of them have to go together. I would choose both a meaningful, reflective hazard allowance and a comprehensive health insurance. You see, what we miss out here, what Nigeria spends to train one doctor is a whole lot that is not, it doesn't seem to be appreciated by the nation. What it spends to train one doctor who will stay just a few years and immigrate to the developed world and practice and is better taken care of there. So I will go for both a reflective, meaningful, realistic hazard allowance and a comprehensive health insurance, especially for healthcare workers.
Okay, thank you very much, sir, for that thought. Are we still able to get Dr. Kwano on the line? Just to get some last words from him. Okay, if we're unable to do that, our time is already very well spent. But last question I have for you, which I'd like you to answer, Dr. Okoro, and also give your last remarks, is this interprofessional wrangling in the health sector, where it appears the various professional groups are almost always at loggerheads with one another. You know, do you think that these issues around universal health coverage, around better welfare, health insurance coverage, increased hazard allowance, is something that can bring them together, as one of the things that could help to improve the morale and possibly reduce, migration of healthcare workers to other countries?
I completely agree that it is an issue that can bring all health workers together. We all are working in the same environment and facing health risks, although some are more exposed than others, as a matter of fact. So it's an issue that can bring all health workers together. Let us all advocate for a realistic health hazard allowance, and then also a realistic, comprehensive health insurance coverage for all health workers.
Thank you very much, Dr. Kenneth Okoro, for joining us from Abakaliki. Dr. Kenneth Okoro is a consultant pediatrician at the Alex Ekwueme Federal University Teaching Hospital in Abakaliki. He was also National Secretary of Nigerian Medical Association many years ago, I think around 2008, 2009. Thanks for being with us on the program once again.
Thank you.
Okay, I'm told Dr. Chimezie is back on the line, but unfortunately our program, our time is really up. Perhaps we'll schedule another time to have this conversation with Dr. Chimezie Kwano. I wanted to find out from him the cost of kidney transplant, the cost of kidney biopsy, and some of these kidney issues, being that is the disease that the two medical doctors we mentioned are trying to sort out. But technology didn't allow us to quite have that conversation with him. But we'll dedicate a full program to talk about kidney diseases, and I hope Dr. Okwano will be able to join us. Thank you, our viewers, for being part of the program. Please keep following us our social media handles displayed on your screen, and also subscribe to the YouTube channel Talk Health Nigeria TV, so that you can always watch this program as many times as you like, as well as previous episodes. My name is Dr. Lars. See you again, same station, same time next week. Bye for now.